All right, everyone. You've got those exams looming, and trust me, we know the feeling. Today, we're taking on a massive, interconnected challenge that's absolutely crucial for your success as third-year medical students. Cardiac valvular disease, infective endocarditis, and congenital heart disease. We're going to pull it all together through the essential lenses of the cardiac cycle and clinical microbiology.
Yeah, this isn't just about memorizing facts for the test.
No, definitely not. It's about giving you the comprehensive understanding you need, building true insight so these concepts stick, not just for the test, but for your entire medical career.
That's our mission, exactly. We want to unpack these intricate systems, clarify their pathogenesis, the nitty-gritty pathology, how they show up clinically at the bedside, how we diagnose them effectively, and critically, how we manage them.
And really highlighting the differences, right?
Yeah. Yes, highlighting the subtle but vital distinctions that truly set one condition apart from another. We've distilled a significant stack of your core lecture materials for this deep dive, everything from the cardiac cycle and disease to a two-part series on infective endocarditis, valvular disease, congenital heart disease, and of course the ever-important clinical microbiology.
Sounds like a lot, but we'll break it down.
We're pulling out the most vital nuggets from each, giving you that full, interconnected picture.
So let's get into the heart of it literally by starting with the heart's own gatekeepers. Its valves. They're often the first line of defense or attack in many cardiac conditions.
To set the stage, let's quickly remind ourselves about the heart's four valves: the aortic and mitral on the left side, and the pulmonary and tricuspid on the right side.
Right, the four doors.
Now, here's a crucial point that you'll see reflected in almost every statistic on valvular disease. The left side of the heart, those aortic and mitral valves, are far more frequently affected by disorders.
And why is that?
Simple mechanics, really. They're handling the systemic circulation, demanding far greater pressures compared to the lower pressure pulmonary circulation on the right. More pressure, more wear and tear, more stress.
Right, so it's a bit like the high traffic side of a highway, taking more damage.
Exactly.
Now, when those doors of the heart aren't working right, it generally boils down to one of two core problems. First, stenosis. Think of this as a tight valve. It's when a valve fails to open completely, impeding forward blood flow. Imagine trying to push blood through a perpetually half-closed door.
And then the opposite problem is insufficiency or regurgitation. We often call this a floppy or leaky valve.
Leaky, right.
Here, the valve fails to close completely, allowing blood to flow backward or reverse when it absolutely shouldn't. It's like a leaky faucet within the heart.
And these aren't always separate issues.
No, it's important to remember that these aren't mutually exclusive. You can have both stenosis and insufficiency coexisting on the same valve, and these issues can affect single or multiple valves simultaneously.
So the clinical picture can get complex fast.
Oh, absolutely. The clinical picture, as you'd expect, is a symphony of symptoms dictated by which valve is involved, how severe the impairment is, and how quickly it all developed.
So what kicks off these problems? What are the main culprits behind valvular heart disease? Let's start with the big one. Calcification or a valvular degeneration?
Yeah, that's a common one.
This is where we often see that familiar enemy wear and tear.
Indeed. Take calcific aortic stenosis, or CAS, for example. This is fundamentally an age-associated wear and tear disorder, startlingly similar to atherosclerosis, the hardening of your arteries.
Really? Similar to blocked arteries?
Yes. It involves the buildup of calcium and fatty deposits. It can develop in initially normal aortic valves or, quite commonly, in congenital bicuspid valves, which we'll discuss in a moment.
Okay.
Its risk factors, things like hyperlipidemia, hypertension, and inflammation mirror almost perfectly those for coronary artery disease. So the same processes that can block your arteries can stiffen your heart valves.
That's a powerful connection. Really makes you think about systemic health. Pathologically, what happens in CAS? What does it look like?
Well, you get these calcified masses forming within the aortic cusps, literally turning the flexible valve into a stiff, rocky obstruction. These masses then protrude through the outflow surfaces, preventing the cusps from opening normally.
Okay, so a physical blockage.
Right. The immediate outcome. Significant outflow obstruction leading to pressure overload in the left ventricle, which then compensates by developing left ventricular hypertrophy. Its muscle wall thickens to try and push against that resistance.
Heart's bulking up to cope.
Exactly. Interestingly, the mitral valve usually remains normal in CS, and the definitive management is often valve replacement.
You mentioned congenital bicuspid valves earlier. Let's talk about those.
Precisely. Now, speaking of congenital bicuspid aortic valves, this is a really common congenital heart defect affecting about 1% of the population.
1%? Wow.
Yeah. Instead of the usual three cusps that efficiently manage blood flow, these individuals are born with just two. Imagine two unequal cusps trying to do the work of three over a lifetime.
That sounds like a setup for problems.
It inevitably predisposes them to earlier mechanical damage and accelerated calcific deposits. So while it's a birth defect, it often manifests as a tightly stenotic aortic valve later in life, often decades earlier than CAS in a trileaflet valve.
And there's another risk with these valves, right?
Yes, and a critical point for your understanding. These structurally abnormal valves are significantly predisposed to infective endocarditis because the turbulent flow creates perfect spots for bacteria to latch on.
Which is a perfect segue to our next major topic. But before we get there, let's briefly touch on mitral annular calcification, or MAC. What's that about?
So MAC involves the fibrous annulus, the ring at the base of the mitral valve leaflets. You see these irregular, hard, sometimes even ulcerated nodules forming there. What's interesting and a key distinction is that MAC usually doesn't directly affect the actual valvular function itself. The leaflets themselves might be fine.
But it's not harmless, is it?
No, definitely not. It still carries significant risks. Specifically, the risk of thrombus formation on those calcified surfaces, which can then embolize and travel elsewhere in the body.
Like little clots breaking off.
Exactly. And just like the bicuspid aortic valve, it can serve as a nidus, a breeding ground for infective endocarditis.
That's a crucial point of differentiation. Beyond calcification, valvular degeneration can also stem from connective tissue disorders.
Right. The prime example here is myxomatous degeneration, which underlies mitral valve prolapse, or MVP.
MVP, okay. What's happening there?
In MVP, one or both of the mitral valve leaflets become floppy and bulge, or prolapse, back into the left atrium during ventricular contraction.
So the leaflets themselves are enlarged, redundant, thick, and feel quite rubbery.
That's a good description. It's like the scaffolding of the valve isn't quite right, making them floppy.
And it affects more than just the leaflets.
Yeah, you can see associated features like elongated, thinned, or even ruptured tendinous cords, which are those crucial strings that hold the valve in place, or a dilated annulus, the ring itself.
What causes this?
Well, the exact cause is often unknown, but it's notably associated with connective tissue disorders, where the body's connective tissue, its structural glue, is a bit faulty, the most famous example being Marfan syndrome.
Marfan. Didn't Abraham Lincoln supposedly have that?
That's the historical anecdote, yes. Abraham Lincoln is often believed to have had Marfan syndrome, a surprising historical connection to a medical condition.
A fascinating insight that personalizes the pathology.
It does. Lastly, and as we transition to our next major section, microorganisms are also a profound cause of valvular degeneration and dysfunction. We're talking specifically about rheumatic heart disease and infective endocarditis, both of which we need to understand in much greater detail.
Okay, let's unpack rheumatic heart disease, or RHD. This is crucial for your understanding of immunology in action, because it's a classic example of your immune system tragically backfiring.
It absolutely is. RHD is an acute, immunologically mediated, multi-system inflammatory disease. It doesn't just happen out of the blue. It typically develops a few weeks after an episode of Group A streptococcal pharyngitis, what you commonly know as strep throat.
Strep throat, okay, that's common.
Very. But interestingly, it can also follow streptococcal infections at other sites like the skin, though pharyngitis is the most common trigger.
So how does strep throat lead to heart problems?
The pathogenesis is a prime example of molecular mimicry. Essentially, your body's immune response, specifically antibodies, and CD4 T cells that are directed against the streptococcal M proteins, which are a major virulence factor for strep and Stakenly cross-react with similar-looking self-antigens found in your own heart tissue.
So your immune system is essentially attacking its own heart because it looks too much like the strep bacteria it was supposed to fight. That's quite the biological betrayal.
Exactly. This antibody binding then activates the complement system, recruiting inflammatory cells like neutrophils and macrophages. T cells also get involved, stimulating cytokine production. All of this culminates in significant damage to the heart tissue through both antibody and T-cell mediated reactions.
Which explains that saying.
Right. Rheumatic fever licks the joints but bites the heart. It's so memorable and accurate. While it can cause transient joint pain, the heart damage is often permanent and cumulative.
That's a powerful phrase, really drives home the danger to the heart. So how do we diagnose this clinically at the bedside?
For diagnosis, we rely on the Jones criteria. This is a clinical checklist. You need either 2 major criteria or 1 major and 2 minor criteria following a confirmed group A strep infection to make a diagnosis of acute rheumatic fever.
Okay, what are the major criteria?
The major criteria include pancreatitis, meaning inflammation of all layers of the heart, the pericardium, myocardium, and endocardium; migratory polyarthritis, which is painful inflammation that tends to jump between large joints; subcutaneous nodules, small, firm, painless lumps under the skin, typically over bony prominences;
Okay.
distinct skin rashes like erythema marginatum, which are pink rings with clear centers; and sedentary chorea, a neurological disorder characterized by involuntary, jerky movements.
And the minor criteria.
Minor criteria include a recent history of a sore throat, arthralgia, joint pain without the full inflammation of arthritis, fever, elevated acute phase reactants like ESR and CRP, and specific ECG changes.
When does this usually show up?
Acute rheumatic fever typically shows up between 10 days to 6 weeks after the initial group A strep infection, usually in children aged 5 to 15 years. They might present with signs of carditis and arthritis, and you might hear pericardial friction rubs, note tachycardia or arrhythmias due to the myocarditis.
Then it can come back.
Critically, yes. After the initial attack, these patients have an increased vulnerability to reactivation with subsequent pharyngeal infections, and the damage to their heart valves is cumulative, meaning with each attack, the damage worsens, potentially leading to irreversible valvular disease.
That cumulative damage really makes prevention and early treatment so vital. What does this look like pathologically? What do you see under the microscope or with the naked eye?
In the acute phase, we see pancreatitis, affecting all layers. The appearance of the pericarditis is famously called bread and butter due to the thick, fibrinous exudate.
Bread and butter.
Yeah, it looks like slices of buttered bread stuck together. Microscopically, the distinctive lesions, which are uniquely characteristic of rheumatic heart disease, are called Aschoff bodies.
Aschoff bodies, right?
These are granulomas consisting of T lymphocytes, plasma cells, and activated macrophages, which are specifically termed Onichkov cells.
Donichkov cells. Any way to remember those?
Onichkov cells are quite unique. Their nuclear chromatin has a wavy, caterpillar-like appearance, giving them the nickname caterpillar cells. That's a great visual to remember them by.
Those caterpillar cells definitely stick in your mind. And what about the valves themselves in this acute phase?
In the acute phase, you see small, wart-like growths called vegetations developing at the lines of apposition on the mitral and aortic valves where the leaflets touch. These are composed of fibrin and platelets with underlying granulation tissue, which is the body's attempt at healing.
So not infectious vegetations yet.
Not yet. These are sterile inflammatory vegetations initially. Over time, as the acute inflammation subsides, this fibrinous material gets incorporated into the valve substance. This leads to progressive thickening, fibrosis, and distortion of the valve leaflets. Initially, you might even see dilatation of the mitral ring and elongation of chordae tendineae, which can actually lead to severe mitral insufficiency at this early stage.
So that acute inflammation really sets the stage for chronic long-term problems, which brings us to chronic rheumatic valvular disease. What are its key defining features?
The most significant long-term consequence, and a very high yield point for your exams, is valvular stenosis, particularly of the mitral valve.
Mitral stenosis.
Yes. In fact, chronic rheumatic heart disease is virtually the only cause of isolated mitral valve stenosis. Remember how in the acute phase, the chordae tendineae can become sticky?
Right.
Well, during the healing process, they fuse together and shorten, much like a scar contracting. This pulls the valve leaflets down, preventing proper opening and often leading to valvular incompetence, especially of the mitral valve. You also see characteristic leaflet thickening and rigidity.
And it creates a very specific, almost iconic appearance, doesn't it?
Yes, it does. In rheumatic mitral stenosis, the extensive calcification and fibrous bridging across the valvular commissures, the points where the valve leaflets meet, create a classic fish mouth or buttonhole stenosis. It's a very distinctive pathological visual.
Fish mouth. Wow. And the complications.
The complications of type mitral stenosis are severe. Progressive left atrial dilation, which significantly increases the risk of mural thrombi forming within the atrium. These thrombi can then embolize, leading to serious thromboembolic complications like strokes.
Strokes, okay.
There's also an increased risk of infective endocarditis on these damaged valves and, ultimately, the relentless progression to heart failure.
This all hinges on understanding how the heart actually works. So let's dive into part 3. The cardiac cycle and valvular impact. understanding the hemodynamic symphony. For you, as third-year medical students, truly grasping the mechanics of the cardiac cycle is your Rosetta Stone for deciphering valvular disease.
Absolutely.
We're not going to reteach the basics from scratch, but focus on the crucial moments and pressure changes that you need to nail down for clinical reasoning.
Exactly. Let's briefly hit the high points of the normal cardiac cycle, emphasizing pressure changes in the atria, ventricles, and aorta, and how these meticulously choreograph valve opening and closing. We typically start our cycle in diastole, the heart's relaxation and filling phase.
Filling phases.
Here, the aortic valve is closed because aortic pressure is higher than the ventricular pressure. Meanwhile, there is passive filling of the left ventricle. Atrial pressure is slightly higher than ventricular pressure, allowing blood to flow from the left atrium into the left ventricle, with the mitral valve open. The key here is filling.
Then, the atria contract. This is an active squeeze, pushing the last bit of blood from the atria into the ventricles, topping off ventricular filling.
Right. You'll see a slight increase in both atrial and ventricular pressure during this active kick. Next, as the ventricular muscle begins to contract, we enter isovolumic contraction. The moment ventricular pressure exceeds atrial pressure, the mitral valve snaps shut. This closure generates the first heart sound, S1, or the classic lub sound.
Loop. Got it.
At this point, ventricular pressure is still lower than aortic pressure, so the aortic valve remains closed. Crucially, no blood is being ejected, and the volume in the ventricle stays the same, hence isovolumic. It's a closed box building pressure.
After that, ventricular pressure continues to build until it finally exceeds aortic pressure. This is when the ejection phase begins.
Exactly. The aortic valve opens and blood is rapidly ejected from the left ventricle into the aorta. Ventricular pressure rises to its peak, representing systolic blood pressure, then starts to fall as the ventricle empties. This is your powerful pump phase.
The big squeeze.
Precisely. As the ventricles relax, we enter isovolumic relaxation. Ventricular pressure falls below aortic pressure, causing the aortic valve to close, which creates the second heart sound, S2, or the dub sound.
Dub, dub.
The mitral valve remains closed because ventricular pressure is still higher than atrial pressure, and again, no volume change occurs in the ventricle. It's another closed box, this time losing pressure. Finally, when ventricular pressure falls below atrial pressure, the mitral valve reopens and we cycle back to passive filling.
And you mentioned some waves earlier.
Yes. Those characteristic pressure changes in the atrium, seen as AC and V waves, become clinically significant on the right side of the heart, where they can be palpated as increased jugular venous pressure, a key sign of right heart failure.
Okay, important clinical link there. Now let's talk about altered heart sounds and murmurs. Normal blood flow is laminar and silent. So if you hear sounds murmurs, it means there's turbulent flow.
That's the key. Turbulence.
It's like hearing rapids in a smooth river.
Exactly. Murmurs indicate that the Reynolds number, a critical threshold for turbulent flow in fluids, has been exceeded. What determines this? Primarily, the diameter of the vessel, the velocity of the blood flow, and the blood's viscosity.
So things like a narrow valve.
Right, a narrow radius, like a stenotic valve, or an increased volume of blood moving through a normal opening, such as in a septal defect, or even decreased blood viscosity, as seen in severe anemia. All of these can lead to turbulent flow and thus a murmur.
And beyond the usual lub-dub, you might hear additional heart sounds like S3, S4, or an opening snap. What do those mean?
Good question. An S3 can signify increased filling rate or volume, often heard in conditions like left ventricular failure, reflecting rapid ventricular filling into a stiff or volume overloaded ventricle.
Okay, S3 is about fast filling.
And S4 suggests increased resistance to ventricular filling, perhaps due to a stiff, non-compliant ventricle struggling to accept blood. Think atrial kick against a stiff wall.
And the opening snap.
An opening snap, on the other hand, is the sharp, sudden sound of a stiff stenotic valve, like a mitral valve being forced open.
So these extra sounds are red flags.
These additional sounds are incredibly important because they often flag the presence of heart failure or significant hemodynamic stress. An S3 or S4 especially can be a strong indicator of increased left ventricular filling pressures.
And that leads us to the absolutely critical chain of consequences of increased left-sided pressures, which is fundamental for understanding the progression to heart failure and valvular disease.
Yes, this cascade is vital for you to master. If you have increased left ventricular pressure, say, from a stiff aortic valve, it inevitably backs up, leading to increased left atrial pressure.
Makes sense. Back pressure.
Since there's no valve between the left atrium and the pulmonary veins, that increased pressure transmits directly back into the pulmonary veins, then to increased pulmonary capillary hydrostatic pressure. This forces fluid out of the capillaries into the tiny air sacs of the lungs, resulting in pulmonary edema.
Pulmonary edema fluid in the lungs. That's what you see on X-ray, or hear as crackles.
Exactly. Classic signs you might see as infiltrates on an X-ray or hear as crackles on exam. And the effects don't stop there.
It keeps going.
Oh, yes. The chronic increased pressure in the pulmonary circulation leads to increased pulmonary artery pressures. This then significantly increases the afterload on the right side of the heart. The right ventricle has to work much harder to pump blood into these high-pressure lungs,
Which leads to?
leading to right ventricular hypertrophy and eventually right ventricular failure. It's a systemic domino effect.
And the systemic consequences of right heart failure are profound and clinically identifiable, things you'll see at the bedside.
Absolutely. Increased right atrial pressure backs up into the superior and inferior vena cava. Increased SVC pressure causes a distended jugular venous pressure. You can even palpate those A, C, and V waves we discussed earlier in the jugular vein.
That neck vein bulging.
Yes. From the IVC, increased pressure leads to increased systemic capillary hydrostatic pressure, resulting in hepatic edema and hepatomegaly, an enlarged tender liver, ascites, fluid in the abdomen, and classic peripheral edema, often seen as pitting edema in the ankles.
Swollen ankle, swollen belly.
These are all signs telling you the right side of the heart is struggling to keep up.
Now let's apply this understanding to specific valvular disorders and their unique impact on the cardiac cycle, comparing each to the normal symphony we just outlined. First, mitral stenosis. A stiff, narrow mitral valve impedes blood flow from the left atrium to the left ventricle.
Right, so in diastole, because that valve is so stiff, there's increased pressure needed to open it, causing a sudden opening snap as it buckles open.
To that snap we mentioned.
Then, as blood struggles to flow through that narrow opening, you get turbulent flow from mid-diastole, which creates a classic diastolic murmur, often heard as a low-pitched rumble, and can even lead to an accentuated, extended S1 sound as the valve forcefully closes.
Okay, diastolic rumble. What about the consequences for the heart chambers?
Consequences for the left atrium are significant. It doesn't empty well, leading to chronic enlargement and persistently increased left atrial pressure during diastole. As we just learned, this directly translates to pulmonary edema and, if uncorrected, eventually right-sided heart failure.
And the left ventricle.
In terms of the left ventricle and systemic circulation, less blood enters the left ventricle due to poor filling. This means less stretching of the cardiac muscle, which reduces the Frank-Starling effect, leading to a less forceful contraction.
So weaker pump.
Essentially, yes. The result is a decreased stroke volume, decreased systolic blood pressure, a diminished pulse volume that you can feel, and, crucially, exercise intolerance. All classic signs of heart failure because the heart simply can't fill effectively.
Moving on to mitral incompetence or regurgitation. Here, the mitral valve doesn't close properly, allowing blood to flow backward into the left atrium during systole when it should be going forward into the aorta.
Correct. In systole, the hallmark is a decreased S1 intensity because the valve isn't snapping shut effectively, it's leaky.
Makes sense. Less of a snap.
This significant backflow into the left atrium creates turbulent flow throughout ventricular contraction, resulting in a holosystolic or pansystolic murmur that you'd hear for the duration of systole.
A murmur throughout systole.
Right. The left atrium faces increased filling with each beat, leading to its enlargement and chronically increased left atrial pressure, again predisposing to pulmonary edema and eventual right heart failure.
And the ventricle's perspective.
From the left ventricle's perspective, not all the blood is ejected forward through the aorta. This leads to a decreased effective stroke volume, reduced peak pressure in the aorta, and lower cardiac output overall, again causing exercise intolerance and a reduced pulse volume. The heart is pumping hard, but a significant portion of its effort is wasted by pushing blood backward.
Inefficient. Next, aortic stenosis. This is where the aortic valve is stiff and narrow, making it incredibly difficult for the left ventricle to eject blood into the aorta.
Yes. During systole, as the left ventricle tries to force blood through that stiff, unyielding valve, you hear a characteristic systolic ejection murmur due to the turbulent flow, often described as crescendo decrescendo.
Crescendo decrescendo. Louder than quieter.
Exactly. The left ventricle has to generate significantly increased systolic pressures to overcome this resistance. This leads to profound left ventricular hypertrophy, a compensatory mechanism where the heart muscle thickens dramatically to handle the increased afterload. We often describe this as the heart building more and more muscle to push against a perpetually closed or narrowed door.
That compensation works for a while, right? But it's not sustainable in the long term, and that's the clinical problem.
Exactly. While hypertrophy initially helps overcome the increased afterload, the ventricle eventually decompensates. The muscle becomes too thick, stiff, and less efficient. This poor pump function leads to decreased stroke volume and cardiac output, a diminished pulse volume, and exercise intolerance.
And eventually.
Ultimately, if the left ventricle can't generate sufficient pressure, you see decreased aortic blood pressure. Furthermore, because less blood is ejected, there are increased end-systolic volumes in the left ventricle, which means increased left ventricular filling pressures, increased left atrial pressures, pulmonary edema, and eventually right heart failure. It's a full systemic collapse stemming from that initial valvular problem at the aortic door.
Finally, let's consider aortic incompetence or regurgitation. In this scenario, the aortic valve doesn't seal properly, allowing blood to flow backward from the aorta into the left ventricle during diastole, when it should be filling from the atrium.
Right. The key here is that backflow from the aorta. During diastole, as blood rushes backward into the left ventricle, you hear a characteristic diastolic decrescendo murmur.
Diastolic, getting quieter.
Yes. Systemically, you can see classic signs. A bounding peripheral pulse due to the large volume of blood, or even de Musset's sign, which is a bobbing of the head with each heartbeat due to the large pulse pressure.
Head bobbing, wow.
Yeah, quite striking. Blood pressure-wise, you get a rapid decline in aortic blood pressure during diastole because blood is leaking back into the ventricle, resulting in a much lower diastolic pressure.
Okay, low diastolic. What about systolic?
When this low diastolic is combined with an increased systolic pressure, because the left ventricle is filling with extra blood during diastole, both from the atrium and the regurgitant aorta, it stretches more, leading to a more forceful contraction and higher systolic pressure. The result is a significantly increased or wide pulse pressure. That's a hallmark of aortic incompetence.
Wide pulse pressure, key sign.
Very key. Despite the powerful systolic contraction, overall cardiac output is decreased as so much blood is just shuttling back and forth, again leading to exercise intolerance and symptoms of heart failure.
It's clear that these valvular problems on the left side have far-reaching systemic consequences. And just to reiterate, similar problems can certainly occur on the right side of the heart, involving the tricuspid and pulmonary valves, with analogous hemodynamic and clinical consequences.
Absolutely.
Just manifesting as right-sided clinical signs like that distended jugular venous pressure or peripheral edema rather than pulmonary congestion.
Absolutely.
Yeah.
The principles of blood flow and pressure dynamics remain the same. Understanding the left side thoroughly gives you a strong foundation for understanding the right.
Okay, let's transition from mechanical and structural issues to a biological invasion with part 4. Infective endocarditis microbes on the endocardium. This is a significant threat, both in developed and developing nations, and it's a master of disguise.
Infective endocarditis, or IE, is an infection of the heart valve or the endocardium, the inner lining of the heart. What happens is you get colonization by a microbe, leading to the formation of characteristic vegetations.
Vegetation, those sound bad.
They are. These vegetations are essentially a gruesome mix of thrombotic debris, like fibrin and platelets, combined with the organisms themselves. Crucially, this process causes destruction of the underlying heart tissue.
Can it happen on normal valves?
Yes, it can occur on either normal or already abnormal valves and can affect sites beyond just the valve, such as the aorta, aneurysmal sacs, blood vessels, and particularly prosthetic valves. Prompt diagnosis and treatment are absolutely critical to prevent severe morbidity and mortality.
So who's at risk and where do we see this globally? Does geography or income level change the picture?
Epidemiology varies quite a bit. In high-income countries with increased life expectancy, we're seeing more degenerative valvulopathies, more prosthetic valves being implanted, and a higher incidence of cardiovascular implantable electronic devices.
So more devices, more procedures.
Exactly. Nosocomial or hospital-acquired infections are also prevalent. Staphylococcus aureus has become a more frequent cause here, and right-sided endocarditis related to IV drug use is also common.
And in low-income countries.
In stark contrast, in low-income countries, rheumatic heart disease remains the primary predisposing risk factor for, i.e., scarring valves and making them vulnerable. Streptococcus species are generally more frequent culprits, though 5e drug use is an increasing risk factor in urban southern Africa, for instance.
That shift in epidemiology based on income level is really important to grasp, as it tells you a lot about the underlying health challenges. What are the general risk factors across the board that scream high risk for IE?
Generally, any pre-existing structural abnormality of the heart significantly increases risk. This includes scarred valves from rheumatic heart disease, degenerative valve diseases like senile aortic stenosis or mitral regurgitation, congenital heart defects like VSDs or PDAs, and even mitral valve prolapse.
So damaged valves are a big one.
Huge. Prosthetic valves are a major risk factor, as is IV drug usage, often leading to right-sided endocarditis. Nosocomial infections and the presence of indwelling intravascular devices are also significant, as these provide direct entry points for bacteria. Patients on hemodialysis and those with a prior episode of IE are also at highly increased risk for recurrence.
So how do these vegetations actually form? What's the pathogenesis, step by step, once the bacteria hit the bloodstream?
It starts with a source of bacteria. This could be from an IV drug user with unclean skin during dental procedures that release oral flora, from skin infections, open wounds, or surgical procedures. These bacteria then enter the bloodstream.
Okay, bacteria in the blood, then what?
The crucial next step is that they implant and adhere to a damaged valve or endocardium. This damage might be from pre-existing conditions like RHD, congenital defects, prosthetic valves, or even just high hemodynamic stress creating micro-injuries.
So they need a sticky spot.
Pretty much. The damaged endothelium favors the formation of platelet fibrin thrombi, which is essentially the body trying to patch up the damage. Circulating bacteria then infect these sterile thrombi, proliferate within them, and rapidly form the vegetations.
And these vegetations can be quite dangerous, not just where they are, right? They're like ticking time bombs.
Exactly. A major concern is embolization. Fragments of these vegetations, carrying virulent organisms, can break off and travel through the bloodstream, lodging in distant sites.
Causing problems elsewhere.
Yes. Where they lodge, they can cause septic infarcts, essentially a clot and infection blocking blood supply, or mycotic aneurysms, which are weakened, infected blood vessel walls that can rupture.
And there are different types. Acute versus subacute.
Right. We differentiate between acute IE, caused by highly virulent organisms like Staphylococcus aureus, which is rapidly destructive and often requires urgent surgery, versus subacute IE, which involves less virulent organisms, usually on an already abnormal valve, leading to less destructive vegetations and a slower course, often treatable with antibiotics alone.
Understanding the clinical presentation of IE can be tricky because it varies so widely, making diagnosis quite challenging. But there are some classic peripheral signs that every third-year student absolutely should be able to spot. These are your clinical clues.
Absolutely. Think about these specific clues because they are high yield for both exams and patient care. Petechiae, those tiny red or purple spots, are common and nonspecific, found on extremities, mucosa, and the palate.
Petechiae, okay.
Splinter hemorrhages are characteristic dark, linear streaks found in the nail beds, caused by microemboli.
Streaks under the nails.
Osler nodes are tender, red, often painful papules or pustules on the distal pads of the fingers or toes, caused by immune complex deposition. In contrast, Janeway lesions are painless, erythematous macules found on the palms of the hands or soles of the feet, caused by septic microemboli.
Osler nodes are ouchy, Janeway lesions are not. Got it.
Good way to remember it. You might also look for Roth spots, which are retinal hemorrhages with small clear centers, and conjunctival hemorrhages, bright red or dark red patches on the sclera, and of course unexplained hematuria due to renal microemboli or glomerulonephritis. These peripheral manifestations are crucial diagnostic clues that should trigger your suspicion for IE.
What about the microbiology? Who are the main culprits we're looking for when we suspect IE?
For native valve IE, gram-positive bacteria are the most common. Viridans streptococci are historically the most frequent overall cause, especially following dental work, followed closely by Staphylococcus aureus and enterococci.
Strep, staph, and enterococci. The big three.
Pretty much. Less commonly, you might encounter gram-negative bacilli, specifically the HAC-EEC group, that's Haemophilus, Aggregatobacter, Cardiobacterium, Eikenella, and Kingella species, or Streptococcus pneumonia, Streptococcus pyogenes, and certain group B, C, and G streptococci. Fungi are also a rare but severe cause.
And for specific patient groups, like IV drug users, does the common culprit change?
Yes, significantly. For 5E drug users, the infection is predominantly right-sided, affecting the tricuspid valve, because the injected material goes directly to the right heart. Here, the common organisms are Staphylococcus aureus, often highly virulent Enterococcus faecalis, and Pseudomonas aeruginosa.
Different bugs for different folks. What about when the cultures are negative?
Ah, yes. A particularly challenging scenario is culture negative, i.e., where despite strong clinical suspicion, blood cultures remain negative in up to 20% of cases.
20%. That's quite high. Why?
This can be due to prior antibiotic therapy, inadequate blood sample volume, or fastidious organisms that are difficult to culture, such as the HAC group, Bertella, Coxiella burnetia, Bartonella, Chlamydia, Mycoplasma, or fungi.
So tricky bugs to grow.
Exactly. It's also important to remember that not all endocarditis is infectious. For instance, Liebensack's endocarditis is a non-infectious type seen in patients with systemic lupus erythematosus due to sterile vegetations.
Okay, so you've got the clinical picture, you spotted some red flags, and you're thinking, i.e., how do we definitively diagnose it? The Dukes criteria is your framework, right?
That's right. The modified Dukes criteria is your go-to diagnostic tool. It integrates everything: history, physical exam, risk factors, systemic manifestations, echocardiography, and crucially, blood cultures.
Blood cultures are key then.
For microbiological diagnosis, the blood culture is the single most important lab test. Bacteremia in IE is typically continuous and low grade, which impacts how we collect samples. You need at least 3 sets of blood cultures, with the first and last drawn at least 1 hour apart from different venipuncture sites.
3 sets an hour apart.
Yes. Each set should ideally have a robust volume of 20-30 milliliters of blood. Critically, these must be taken before antibiotic administration, if possible, and you should always inform the microbiology lab if IE is suspected, as this may prompt prolonged incubation times for fastidious organisms.
And what about imaging? How does echocardiography confirm the diagnosis?
Echocardiography is essential for confirming endocardial involvement and finding those vegetations. A transthoracic echocardiogram, TTE, is a good start, but a transesophageal echocardiogram, TEE, offers superior resolution and can detect much smaller lesions, sometimes as tiny as 1 to 1.5 millimeters, which a TTE might miss.
T gets a better look.
It gets you much closer to the heart structures, yes.
So how do the Dukes criteria break down into major and minor categories for definitive diagnosis? What are the absolute non-negotiables, the major pieces of evidence that scream endocarditis?
Let's walk through it. Major criteria include 1. Positive blood cultures with typical microorganisms consistent with IE from 2 separate cultures, or persistently positive cultures drawn over time. For instance, if you get Viridin, Streptococci, or Staph aureus from multiple cultures. A single positive Coxiella burnetii serology with high IgG titers greater than 1.80 also counts as a major criterion, as Coxiella is a known cause of culture-negative IE.
Okay, positive cultures or specific serology. What's the second major?
2. Evidence of endocardial involvement on echocardiography. This means seeing an oscillating intracardiac mass on a valve or its supporting structures, evidence of a pedovalvular or ring abscess, a collection of pus around the valve, a new partial dehiscence of a prosthetic valve, meaning it's coming loose, or new valvular regurgitation. These are direct signs of the infection's damage.
Seeing it on the echo.
Got it.
And the minor criteria, these are the supporting clues, right? The ones that fill in the gaps or raise your suspicion even higher.
Exactly. Minor criteria are 1. A predisposition or risk factor, such as a known heart lesion or IV drug use. 2. A fever of more than 38 degrees C. 3. Vascular phenomena, which include major arterial emboli, a stroke from a septic clot, mycotic aneurysms, conjunctival lesions, or Janeway lesions.
Those peripheral signs we talked about.
Right. 4. Immunological phenomena, such as glomerulonephritis, Osler nodes, Roth spots, or a history of rheumatic fever. These indicate the body's immune response to the infection. 5. Microbiological evidence of a positive blood culture that doesn't quite meet the major criteria, or echocardiographic findings that are consistent with IE but don't quite meet the major criteria.
How do we put these together to get to a definitive or possible, i.e., diagnosis for a patient?
For a definitive diagnosis of IE, you need either direct histological or microbiological evidence of infection obtained at surgery or autopsy. Clinically, it's defined by having 2 major criteria, or 1 major criterion combined with 3 minor criteria, or 5 minor criteria.
Okay, 2 major or 1 major plus 3 minor or 5 minor.
Correct. A possible diagnosis is made with 1 major criterion and 1 minor criterion, or 3 minor criteria. This systematic approach is critical to standardized diagnosis and guide therapy.
Once you have that diagnosis, what are the principles of management and what are the devastating complications you're looking out for?
Management is nuanced and depends on whether it's a native or prosthetic valve and the patient's specific risk factors. The core principles are high-dose, parenteral intravenous antibiotics given for a prolonged duration, typically 4 to 6 weeks.
Long course of 5E antibiotics.
Yes. You also need to repeat blood cultures after about a week of therapy to monitor treatment response and ensure the bacteremia is clearing. For native valve, i.e., empiric therapy often includes penicillin and gentamicin to cover common organisms. If Staphylococcus aureus is suspected, especially in certain epidemiologic contexts like IV drug users, you'd add flucloxacillin.
And then tailor it.
Exactly. Therapy is then adjusted based on the specific organism isolated and its antibiotic susceptibilities. For instance, vancomycin would be used for penicillin-resistant streptococci or resistant enterococci.
And the complications can be devastating, truly multi-system.
They absolutely can. Complications include aneurysm formation, severe valvular incompetence leading to congestive heart failure, and widespread embolization of vegetations, which can cause multi-organ infection, sepsis, brain abscesses, renal infarcts, or lung abscesses.
And prosthetic valves have their own issues.
Yes, with prosthetic valves, you might see loosening of sutures, paraprosthetic leaks, or ring abscesses around the valve, which can rupture and lead to fistulous tracts or intracardiac shunting, severely impacting heart function.
That sounds like a situation where antibiotics alone aren't enough. When is urgent surgery indicated, and what flags it?
Urgent surgery is a key component of management for several critical scenarios. If there's progressive heart failure caused by the valve destruction, multiple systemic embolic episodes indicating pieces are breaking off and causing damage elsewhere, persistent bacteremia despite effective antibiotic therapy, suggesting the antibiotics can't reach the infection well, or fungal endocarditis, which typically causes large, difficult-to-treat vegetations.
So failure, emboli, persistent bugs, fungus.
Right. Also, cardiac complications like heart block, purulent pericarditis, or cardiac abscesses also necessitate surgery, as do relapses following adequate antibiotic trials or prosthetic valve rupture.
And what factors predict a poor outcome for these patients? What are the red flags that make you worry about prognosis?
Several factors contribute to a poor prognosis. Patient factors include old age, prosthetic valve involvement, which is harder to treat, diabetes mellitus, and significant comorbidities. Complications like new or worsening heart failure, renal failure, major ischemic stroke, brain hemorrhage, or septic shock are all major red flags.
Okay, what else?
Certain microorganisms are associated with worse outcomes, notably Staphylococcus aureus, fungi, and non-HSIC gram-negative bacilli. Lastly, specific echocardiographic findings predict poor outcomes. Periannular complications, like abscesses around the valve, severe left-sided valve regurgitation, a low left ventricular ejection fraction, meaning the heart muscle is failing, pulmonary hypertension, large vegetations over 1 centimeter, severe prosthetic valve dysfunction, and premature mitral valve closure. These all indicate severe complex disease that is difficult to manage.
So on that note, let's go even deeper into specialized endocarditis with Part 5. Specialized endocarditis and prevention, specifically prosthetic valve endocarditis, PVE, and how it differs from native valves, i.e. When you have a foreign object in the heart, does the game change entirely?
It absolutely does change the game. Prosthetic valve endocarditis, or PVE, is a significant complication following artificial heart valve placement. We categorize it based on timing, which reflects different pathogenic mechanisms and influences the epidemiology and microbiology.
Okay, timing matters. How?
We talk about early PVE, which occurs within 1 year of surgery, often acquired perioperatively or nosocomially from the hospital environment. Then there's late PVE, which happens more than a year after surgery and is typically community-acquired, often resembling native valve endocarditis.
So the timing tells you a lot about the likely culprit and the source.
Exactly. Now, concerning the types of valves, we have mechanical heart valves made of synthetic materials. They are incredibly durable, designed to last decades, but unfortunately, they are quite thrombogenic, meaning they promote clot formation.
So patients need blood thinners.
Yes. This requires patients to be on long-term anticoagulant therapy. They're also prone to microbial adherence, and infection often occurs at the interface between the sewing cuff and native tissue, leading to complications like paraprosthetic leaks or abscesses.
And the bioprosthetic valves, are they less problematic?
Bioprosthetic heart valves are made of biological tissue, usually from animals or human donors. They are less durable than mechanical valves, typically lasting 10–15 years, but generally do not require long-term anticoagulation.
And infection looks different.
Yes. With these, infection is typically restricted to the cusps themselves, and complications include cusp rupture or perforation.
And which microbes are we typically seeing in PVE? Is it similar to native valve, i.e.?
The microbiology differs slightly from native valve, i.e., particularly in early PVE. Staphylococcus epidermidis, a common skin flora organism, is a frequent cause in early PVE, along with Staphylococcus aureus, Streptococcus species, and Enterococci.
Staph epidermidis, that skin bug again?
Yep. Less commonly, fungi like Candida and Aspergillus and gram-negative organisms, including the HACCI group, can also cause PVE. For late PVE, the microbiology often mirrors native valve, i.e.
How does the presence of a foreign object, like a prosthetic valve, influence the pathogenesis? It must make it harder for the guy to fight.
It does. The prostheses themselves are highly thrombogenic. The sewing cuff fabric, sutures, and any mechanical or inflammatory lesions predispose to infection. The modes of infection include contamination during the insertion surgery, hematogenous spread from another site of infection, or contiguous spread from surrounding tissue.
And the biofilm thing is key here, right?
Absolutely. The crucial factor here is that bacteria adheres tenaciously to the device surface and rapidly form a biofilm, which is a protective layer of bacteria encased in a matrix. This biofilm makes the infection incredibly difficult to treat with antibiotics alone, as the drugs struggle to penetrate it. These infections can then extend locally, causing tissue damage, or release septic emboli to distant sites.
And the complications sound severe. You're fighting an infection on a foreign body, often deep within the heart.
They are. Heart failure is the most common cardiac complication due to valve destruction or dysfunction. Other cardiac issues include perivalvular abscess formation, intracardiac fistulae, abnormal connections, and pericarditis.
And non-cardiac.
Non-cardiac complications can be metastatic abscesses and mycotic aneurysms, which can occur anywhere in the body. Neurological complications like strokes, seizures, and brain abscesses are also significant. Renal complications include infarcts and abscesses, and pulmonary complications range from lung abscesses and pneumonia to pleural effusions. All of these contribute to substantial mortality.
So management for PVE is quite aggressive then. It sounds like device removal is often critical.
Absolutely. Urgent heart valve surgery combined with prolonged parenteral antimicrobial treatment is often needed. Indications for urgent surgery include severe valve dysfunction, abscesses, large vegetations over 1 centimeter with high embolization risk, failure of medical treatment, or recurrence.
And the antibiotics.
Empiric therapy typically involves vancomycin, rifampicin, because it penetrates biofilms effectively, and gentamicin. The duration of therapy is always prolonged, a minimum of 6 weeks, often longer.
We've also got infections of non-valvular cardiovascular devices, like pacemakers or defibrillators. What are the key points there? Do they share similar challenges?
Infections of non-valvular cardiovascular devices, such as permanent pacemakers, implantable cardioverter defibrillators, ICDs, ventricular atrial shunts, and peripheral vascular stents, or grafts, are also important. The pathogenesis is very similar to PVE. Microbial contamination, most commonly with skin flora, occurs at the time of insertion. These microbes adhere to the device surface and produce biofilm, leading to colonization and subsequent infection.
And the usual suspects for these device infections?
Microbiology-wise, coagulus-negative staphylococci, like S. epidermidis, and Staphylococcus aureus are overwhelmingly predominant.
So staph again, how do these present?
Clinically, you might see a pocket site infection with localized inflammation, or sometimes occult bacteremia without obvious local signs, or even device-associated endocarditis if the infection spreads along the leads into the heart.
And the treatment principle?
The management principle here is crucial. Device removal in conjunction with antimicrobial therapy. Simply treating with antibiotics without removing the infected device is often ineffective due to the biofilm's protection.
Got to get the source out. This all leads us to the critical question of prevention of infective endocarditis. It seems like such a severe disease, preventing it would be ideal.
Prevention is vital because, despite advances in treatment, IE can lead to serious morbidity and mortality. Even if a microbial cure is achieved, permanent cardiac valvular damage and other systemic complications are often irreversible, profoundly impacting a patient's quality of life.
So what are the recommendations?
Current recommendations emphasize maintaining optimal oral and dental health in patients at risk, as this reduces the bacterial load. And implementing interventions to prevent and promptly treat healthcare-associated infections is also key.
So what's the current stance on antibiotic prophylaxis? It used to be much broader, right? Many students still learn the old guidelines.
That's correct, and it's a critical point of evolution in medical practice. Antibiotic prophylaxis prior to surgical procedures is no longer the standard of care for most patients. It is now highly restricted
Restricted to who?
to specific dental procedures, those involving manipulation of gingival tissue, the periapical region of teeth, or perforation of the oral mucosa, and only for specific high-risk patients.
Who counts as high risk?
These high-risk patients would include those with prosthetic cardiac valves, a history of previous, i.e., specific complex congenital heart disease, like unrepaired cyanotic CHD or repaired CHD with residual defects, or cardiac transplant recipients who develop valvulopathy.
Okay, a specific list. What do they get?
For these individuals, a single dose of amoxicillin given 30-60 minutes prior to the procedure is recommended. Prophylaxis is also considered reasonable for procedures on the respiratory tract, infected skin, skin structure, or musculoskeletal tissue, again, only for patients with these high-risk cardiac lesions.
And where is it not recommended?
It is generally not recommended for genitourinary or gastrointestinal tract procedures due to low benefit and concerns about antibiotic resistance.
Excellent. Now let's shift gears completely to part 6. Congenital heart disease, a developmental perspective. This is where we look at the heart's journey from early development and often what goes wrong even before birth.
Congenital heart disease, or CHD, refers to structural heart problems present at birth. Its prevalence is significant, affecting about 1% of live births, making it one of the most common birth defects.
1% again. It happens really early in development.
Yes, the crucial period for the insult that causes CHD is remarkably early, before 9 weeks of gestation. This is often before many mothers even know they're pregnant.
So before much of life even begins, the groundwork for a heart defect could be laid. What are the common etiologies, the reasons these defects happen?
Exactly. Etiologies are diverse. Genetic causes include chromosomal anomalies like Down syndrome or trisomy 21, and there can be familial recurrence, meaning it runs in families.
Okay, genetics. What else?
Certain medications taken by the mother during pregnancy are teratogenic, meaning they cause birth defects, such as some epilepsy drugs and retinoic acid or Roaccutane. Maternal factors also play a significant role, including alcohol consumption, which can lead to fetal alcohol syndrome, infections like German measles or rubella syndrome, and poorly controlled diabetes during pregnancy.
So maternal health and exposures are key.
Absolutely. It's important to highlight how these causes fundamentally differ from the heart disease we typically see in adults, which is usually coronary artery disease related to lifestyle choices and atherosclerosis. Children aren't getting heart attacks from smoking and diet like adults.
That's a key distinction for clinical practice. Now, clinically, how do we classify CHD? The pink versus blue approach is classic, and it tells you immediately about oxygenation.
Yes, the pink versus blue classification is fundamental and immediately guides your assessment. As cyanotic, or pink, patients do not typically appear blue because they generally have normal systemic oxygenation.
Okay, pink means enough oxygen. Are there types within that?
Yes. Within this group, some have increased pulmonary blood flow, such as ventricular septal defects, VSDs, patent ductus arteriosus, PDAs, and atrial septal defects, ASDs. These involve left-to-right shunting, meaning oxygenated blood from the higher pressure left side of the heart flows into the lower pressure right side, increasing blood flow to the lungs.
More blood to the lungs. What's the other pink type?
Other asionic patients have normal pulmonary blood flow, but still have defects like pulmonary stenosis, aortic stenosis, or congenital mitral stenosis, which impede flow through their respective valves.
In the cyanotic or blue babies, these are the ones where oxygenation is visibly an issue.
These patients appear blue due to deoxygenated blood entering the systemic circulation. Some cyanotic conditions have increased pulmonary blood flow, like transposition of the great vessels, TGA.
TGA, where the plumbing's swapped.
Exactly, where the aorta arises from the right ventricle and the pulmonary artery from the left, creating two separate parallel circulations, meaning deoxygenated blood goes to the body. Other examples are truncus arteriosus and total anomalous pulmonary venous drainage, TAPVD.
And the other blue type, less blood flow.
On the other hand, some cyanotic conditions are associated with decreased pulmonary blood flow, often seen as oligoemic, underperfused, or dark lungs on X-ray because not enough blood is reaching the lungs for oxygenation. Classic examples here are tetralogy of Fallot, TUF, pulmonary atresia and tricuspid atresia.
It's amazing how these complex structures develop from a simple tube. A quick nod to the embryological basis is in order here the precision involved.
Briefly, the heart starts as two simple heart tubes that fuse to form a single tube. This tube then undergoes a complex looping process, folding on itself, and then septation, the formation of internal walls, to create the four-chambered mature heart.
All in the first 9 weeks.
All of this is largely complete within the first 9 weeks of gestation. Any disruption during this critical, intricate period can lead to CHD, with the specific timing of the insult often determining the type of defect.
And often, these heart defects aren't isolated. They come with other tells, other physical signs, particularly with genetic associations and dysmorphisms that should immediately raise your clinical suspicion.
Precisely. Let's start with chromosomal anomalies. Down syndrome, or trisomy 21, with its extra chromosome 21, is famously associated with CHD. Patients have classical features like upslanting eyes, a large tongue, and a single palmar crease, or simian crease.
And the typical heart lesion in Down syndrome.
Their typical heart lesion is an atrioventricular septal defect, AVSD, where there's a defect in both the atrial and ventricular septa. Other trisomies, like trisomy 13, Patro syndrome, and trisomy 18, Edwards syndrome, also have distinctive features: cleft lip and palate, very low-set ears, and polydactyly or extra digits. Their most common cardiac lesion is a ventricular septal defect, VSD.
Beyond chromosomal issues, what about other syndromes and physical signs we should be looking for?
Fetal alcohol syndrome, caused by maternal alcohol consumption during early pregnancy, presents with characteristic facial features: small, almond-shaped eyes, low-set ears, a thin upper lip, and an absent philtrum, the vertical groove between the nose and upper lip. These children often have microcephaly and mental retardation, and CHD is a common association.
Okay, rubella.
Rubella syndrome, from maternal German measles infection, can cause PDA or peripheral pulmonary stenosis, along with microcephaly and cataracts, which might manifest as a white pupil.
And Turner syndrome, a classic one.
Turner syndrome, XO, affecting females with only one X chromosome, is classic for coarctation of the aorta, a narrowing of the aorta. Physically, you might notice a short fourth metacarpal, leading to a depressed knuckle, non-pitting lymphedema of the feet, and neck webbing.
And other general signs.
Other less specific but important general dysmorphisms include abnormal chest shapes, like pectus excavatum, sunken chest, or a barrel chest, abnormal feet or toes, abnormally low-set ears, where the ear is situated below a line drawn from the medial campus of the eye and clubbing of the digits, indicated by the loss of Shamroth's window. These external signs are crucial clinical clues that should prompt you to look for underlying CHD. They are your body's subtle whispers about internal problems.
It's amazing how much the body signals from the outside what's going on inside. Now, about the complications of uncorrected CHD. If these defects aren't fixed, what happens to the patient?
The most common complication, especially if diagnosis is delayed or treatment is not pursued, is heart failure. This can present as pulmonary edema, pedal edema ascites, facial edema in non-ambulatory children, and a distended jugular vein, indicating right heart failure.
Heart failure and infection again.
Yes, another critical complication and a direct link to what we just discussed is infective endocarditis. In CHD, defects like VSDs create high-velocity blood jets. For instance, a VSD jet hitting the right ventricular wall or tricuspid valve leaflets causes endothelial injury due to the sheer force.
That jet lesion idea.
Exactly. Platelets and fibrin are attracted to this injured area, forming a sterile thrombus. If bacteremia occurs, bacteria can get caught in this clot, multiply, and form a vegetation. These vegetations are prone to embolization, meaning pieces can break off and travel to peripheral arteries, potentially causing septic infarcts and even gangrene of digits or limbs.
So how do we confirm a diagnosis of CHD? What tools are at our disposal in the clinic?
Clinically, the stethoscope is paramount. Murmurs heard in specific locations, like a pansystolic murmur at the lower left sternal border for a VSD, or a continuous murmur below the left clavicle for a PDA, are crucial. Cyanosis is another obvious clinical sign.
And imaging, X-rays.
For imaging, X-rays can reveal classical features such as dextrocardia, heart on the right side, pulmonary prominence indicating hypertension or increased flow, a wall-to-wall heart, cardiomegaly, or oligoamic lungs suggesting decreased pulmonary blood flow.
And echocardiography, which is essentially ultrasound of the heart, right?
Correct. Echocardiography is non-invasive and indispensable. It allows us to visualize the heart's structures in real time, identify defects like ASDs and VSDs, and assess valve function and blood flow dynamics.
What about cardiac catheterization?
Then there's cardiac catheterization, which serves both diagnostic and interventional purposes. Diagnostically, catheters inserted into vessels can measure pressures and oxygen saturations within heart chambers, and angiograms using specialized dye can visualize the outline of chambers and vessels, revealing blockages like coarctation.
And therapeutically, it's quite revolutionary. It can avoid open heart surgery for some defects, which is a huge benefit for patients.
Indeed, catheter-based interventions can close certain defects like ASDs, PDAs, and even some VSDs. A specialized device, like an occluder, is pushed through the catheter and deployed to seal the defect, often avoiding open heart surgery entirely. This technology has significantly advanced and changed the landscape of CHD treatment.
So how are these conditions treated, and what are the challenges, particularly in places like South Africa?
Treatment involves medical management with medications and oxygen, especially for heart failure or to optimize the patient before intervention. But for many structural defects, surgical repair is the main treatment.
Open heart surgery.
Yes, this often means open heart surgery involving a sternotomy, opening the chest, and the use of a bypass machine operated by a perfusionist to allow the surgeon to work on a non-beating heart. A specialized team, including cardiac anesthetists, surgeons, and nurses, is essential for these complex procedures.
And the challenges in South Africa. It sounds like access is a major hurdle.
Despite the dire need, heart surgery is available in only a limited number of teaching centers in South Africa. Surveys indicate a significant unmet need, with thousands of patients born with CHD each year requiring surgery or catheter-based interventions who simply don't receive them. This underscores the critical importance of early diagnosis, enabling more patients to access timely and appropriate treatment, which can be life-saving.
This brings us to part 7, the art of clinical microbiology, interpreting the evidence. This is where all the pieces come together, often in surprising ways, and it's truly as much an art as it is a science.
Indeed. Interpreting microbiological results is a delicate balance between scientific knowledge and astute clinical judgment. It demands a deep understanding of pathogenesis, the normal flora unique to different body sites, and specific microorganism characteristics.
How should we think about it?
Think of it through the damage response framework for host-pathogen interactions. Commensalism refers to our normal flora, our microbiome, existing in a mutualistic relationship with little to no damage. Different body sites, from the skin to the gut to the oral cavity, have distinct microbiomes.
Okay, normal bugs.
Then colonization is a temporary presence of microorganisms that might not be causing disease. Then there's disease, which is the outcome where microbes actually cause damage to the host. The trick is to know which one you're dealing with.
And the presence of normal flora can really complicate interpretation, especially when you're looking at culture results. How do you tell the good guys from the bad guys, or just the innocent bystanders?
Absolutely. Our skin, for instance, is colonized by gram-positives like Staphylococcus species and Corynebacterium. When you take blood or CSF cultures, your needle traverses the skin, leading to potential contamination by these commensals. The challenge then becomes differentiating a true pathogen, an infection, from a contaminant that just got picked up from the skin.
Contaminant versus true infection.
Exactly. Furthermore, in disease states, the normal flora can be profoundly disrupted or altered. So, isolating an organism that isn't typically part of the normal flora for that site doesn't automatically imply pathogenicity. It might just reflect a disturbed microbiome, as seen in conditions like ulcerative colitis, where the gut flora is significantly changed.
So it's all about context. Let's run through a couple of classic case scenarios to drive this home, as this is where students often get tripped up.
First scenario. A 21-year-old healthy adult presents with cellulitis of the groin. You get a blood culture back.
Okay, what if it's Staph aureus?
Staphylococcus aureus. This is a class 3 pathogen, highly virulent across a spectrum of host responses. It is a known cause of cellulitis and bloodstream infections. In this context, it's highly likely to be the cause of the cellulitis and any systemic infection.
Makes sense. What if it's Staph epidermidis?
Staphylococcus epidermidis. This is a class 1 pathogen, a predominant skin commensal, typically of low virulence. It usually causes serious damage only in immunocompromised hosts or when associated with foreign bodies like lines or prosthetic valves. In a healthy patient with cellulitis, it's most likely a contaminant from the skin during blood draw.
Okay, very clear. Now let's change the clinical picture dramatically. Second scenario. First, Staphylococcus aureus on a blood culture of a 55-year-old female, day 1 post-gastroscopy for an upper GI bleed.
Okay. Here, the interpretation shifts dramatically. For the 55-year-old with Staph aureus post-gastroscopy, you need careful interpretation. Staph aureus isn't a typical pathogen for upper GI bleed complications, nor is gastroscopy a major surgical procedure prone to deep Staph aureus infection. While possible, this could very well be colonization or a contaminant from the skin or an occult skin source.
So less likely the culprit here. Now the other case, Staphylococcus epidermidis on a blood culture of a 10-day-old, very low birth weight neonate in the neonatal ICU who has indwelling central lines.
Now this is highly significant. Neonates, especially preterms in the ICU with indwelling lines, are immunocompromised, and their lines are perfect for Staph epidermidis biofilm formation. In this context, Staph epidermidis, despite being a skin commensal in a healthy adult, is a highly likely true pathogen, causing a line-associated bloodstream infection or even endocarditis. Clinical context truly is king.
It's all about that careful detective work. So, what are the general principles for collecting microbiological samples to ensure we get the most accurate, reliable results to guide our treatment decisions?
Several principles are key. Firstly, relevance. For any septic patient, don't just collect a sputum sample for pneumonia. Always get blood cultures, irrespective of the suspected source of sepsis. Many patients will have bacteremia, and blood cultures are often the most important first step.
Blood cultures for sepsis, always.
Secondly, be aware of limitations. Consider normal flora contamination, the quality of the sample. For example, is it pus or just skin exudate? Whether it truly represents the site of disease, and if the site is even accessible. For example, getting a truly representative deep respiratory sample can be difficult without invasive procedures.
So we need to be mindful of those normal floras, especially for skin cultures.
Yes, knowledge of commensals is crucial for interpretation, otherwise you'll be chasing contaminants. And importantly, for surface infections like bed sores or open wounds, always clear away colonizers by cleaning the surface thoroughly before taking a sample.
Clean the wound first.
Yes. Simply swabbing the surface might only yield harmless colonizers like Enterococcus, which aren't typically pathogenic for skin, and you'll miss the true pathogen buried deeper.
And how much detail should we provide to the lab on the request form? Does it really matter?
It matters immensely. Provide sufficient clinical detail. The more clinical context you give, for example, pus swab from left leg of diabetic with chronic wound and draining sinuses, suspected osteomyelitis, versus just pus swab from left leg, the better the lab can assist in interpretation.
Context helps the lab help you.
Exactly. This helps differentiate, say, Pseudomonas from Staph aureus in that context and informs what tests they prioritize. Always contextualize the culture result with the clinical picture and the common presentations of microorganisms. Finally, always assess the validity of the result and whether it truly mandates treatment or changes to antimicrobial therapy. Not every positive culture result means you need to start or change antibiotics. It might be a contaminant or colonization.
And for blood cultures specifically, you mentioned volume is crucial. How much blood should we really be putting in those bottles?
It is paramount. Volume is critical to yield. A greater volume of blood collected means a better chance of isolating the causative organism, especially in low-grade bacteremia like IE. Ensure bottles are filled adequately, typically 20-30 milliliters per set, to maximize sensitivity.
Fill them up.
Yes. Also, familiarize yourself with your local lab's bottle types, aerobic and anaerobic, and be aware that many bottles contain antimicrobial inhibitors like charcoal or resin. These substances bind residual antibiotics in the patient's blood, facilitating organism growth even if the patient is already on antimicrobials. This significantly increases the yield for finding the true culprit.
We've really taken a deep dive into the heart, from the microscopic damage of rheumatic fever to the mechanical challenges of stenotic valves, the microbial battles in endocarditis, the developmental mysteries of congenital heart disease, and the crucial nuances of interpreting microbiology results.
Remember, these topics aren't isolated. They're interconnected, forming a complex tapestry of cardiac pathology. For your upcoming exams, and more importantly, for your clinical practice, it's not just about knowing the facts, but truly understanding the why behind the clinical presentations, the how of diagnostic approaches, and the so what of management decisions.
Your ability to connect these dots, informed by a deep understanding of basic science, will be your most powerful diagnostic tool. So as you move forward and step onto the wards, consider how the subtle signs you observe at the bedside, like a change in a heart sound you've just learned to identify, or a new rash, can be the initial thread that unravels an entire complex pathological story within the cardiovascular system.
Keep asking.
Keep asking yourselves,
Sure.
what does this all mean for this patient standing right in front of me?